Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of osteoporosis. Dr. Travis Brown, I hope you like the fact that I've got an ice-cold glass of milk in front of you because we're talking osteoporosis and all I remember growing up was you drink milk, that'll solve everything.
Well, did you drink milk? Were you good?
I did actually, although often with a spoonful of Nesquik or Milo in it. Probably undid the
Oh man,
goodness.
after my own heart, no, I'm sort of too addicted to Milo myself. But this was eat the cheese,
Yes.
drink the milk, good for your bone health. And look, we are talking about osteoporosis. Actually, this is a bit of an interesting challenge for us this episode. Technical challenge for yourself. Why is that, Steve?
Oh, well, we recorded this live on stage at the Adelaide Convention Centre, and we had an arrangement of 3 guests, one of whom was dialing in via Zoom, and so that just required an extra bit of logistics to make it happen. But as you hear, it all works seamlessly in the end.
Yeah, it worked really well. And so we were able to discuss with Dr. Alecia Macrow, Dr. Nick Kasmeredis, and Dr. Steve Soukoulis. And so we have these guests that we pretty much sort of put all the episode in one big go as opposed to having guest. We had them all together. And so this was enjoyable. We had discussion in front of an audience. And look, when we lead into osteoporosis, the challenge is that this is a really a significant disease that has lots of associated risks with it. Like if you get a fracture, we know your health just deteriorates, and that is discussed, throughout this episode. And so it's actually really about prevention. And from the historical point, actually, osteoporosis has been around as long as we've been around. Now, patients getting to older age, well, that's a bit different, but we've got now patients regularly getting to older age. There was a story I came across where they actually moved Napoleon's bones when he was considered not an outcast, and France wanted to, bring him back, bring the conqueror back from the despot area. They actually picked up his bones, and they found his bones were actually really light. Unexpectedly light. And there was a query of, did he have osteoporosis? And there's even the term that we call, that historically we say is a dowager. Now this comes from the dowager hump. This is the 18th to the 19th century in England. Now this is when married couples were landowners, and if the husband died before the wife, we would ordinarily say they're a widow, but because they owned land, they became a dower. And if you have a dower share, it was a legal term that the wife, the now widow, the dower, was entitled to 1/3 of the volume of the deceased husband's estate.
1/3.
1/3. I'm not sure what happened to the other 2/3, but you would get the wife would then get 1/3 for the rest of her life from that estate, from the income. Now, the husband could actually change this in his will and give it more or less. This was what the term came past as a dowager's hump, which you'll have heard. And this is the kyphosis in the spine. And what this was associated with is this is most likely associated with osteoporotic fractures of the spine. And as women get elderly, they sort of hunch forward. And so this is where that term comes from, a dowager hump. It actually, not necessarily associated with aristocracy or anything, but it's actually fragility and elderly. And so when we look at osteoporosis, the regions where people get fractures is the wrist, neck of femur, and crush fractures of the vertebrae. And so this is when we're starting to see what we can do for patients, how we can prevent this. It's a reduction in mineralized bone. And so when we look at this, the people are at risk: elderly patients, postmenopausal women, low muscle mass, history of fractures, even ethnicity plays into this. So Caucasians are far more at risk than African Americans, risk of falls, people who have had long-term steroid use. And so if we look at who is the most at risk, 40% of postmenopausal women can be affected and have a lifetime risk fracture of about 40%. But men are also at risk, but they tend to be about 10 years behind women. And this is because often postmenopausal, as we'll discuss, hormonal changes in the menopause actually increases the amount of bone resorption that happens, and it can really drastically reduce mineralization of the bone. And so, but coming back to men aged 60 have a lifetime risk osteoporotic fracture of about 25%. So it's still significant. And if we look at nursing home residents, 85% of nursing home residents worldwide have osteoporosis.
85%.
And so this is the challenge that are facing doctors, health professionals, physios, and this is where we need to find how can we better serve our patients, how can we treat them better, and where do we need to go. And there is one last point just before.
Yes.
Dr. Alecia Macrow, after the conference, said there was one thing she really wanted to emphasize, and this was the importance of heavy lifting. So when we're talking about exercise is excellent, really good, but she said she wanted to stress the importance of heavy lifting. And when she talks about heavy lifting, we're talking about if you're doing 6 reps, we're talking about getting patients on their 6th one are really struggling. Now, this is talking about in a safe environment, because everyone's talking about, I don't want to exercise too much to risk a fracture. If they're able to do it safely, you're talking about heavy lifting. And so this is where you say, I'll do light stuff. No, most benefit is on a par with medication. Doing really heavy weights for these patients, they will get the most benefit from it.
All right, on that note, I'll carry you out of the studio. Our next guest is Dr. Alecia Macrow, a general practitioner and owner of Thrive Family Practice in Adelaide. She has broad interests across primary care and has an interest in women's health.
You're a general practitioner. When we're looking at this, when do you start to think of bone health and osteoporosis in patients?
Thank you so much for having me along. I almost think of those as being 2 separate questions in terms of when I would start thinking about it. In terms of bone health itself, I don't think we can start thinking about it as GPs too early. Even when we start thinking about osteoporosis, I think that's a slightly different question. In terms of the development of osteoporosis, the best framework that I've heard, or the best analogy that I've heard about bone density and risk later for osteoporosis is thinking about bones as a glider and your bone density as a glider. So there's a few things that will change the level of peak bone density that you'll get to in your lifetime. Some of that's going to be genetic, some of that's going to be lifestyle, diet, your overall health and so forth. So with your bone density, you're only ever going to get your glider up so high, and that's going to be in your sort of early adulthood, and from there you've only got one way to go. So if we are thinking about our kids that we're seeing in general practice, actually thinking about their nutrition and their access to sunlight and their physical activity is a really important time to be thinking about their bone health moving forward. we all see the teenagers who want to spend their days inside playing games, lying on their bed, and for a number of reasons that's not good for them, and bone health included. So in terms of us as GPs thinking about bone health in our patients, I don't think there is a time that we can be too early doing that. In fact, I've even heard things like in utero health important as well. In terms of osteoporosis, I think that's a slightly different story. So I think I start wanting to think about osteoporosis if someone is coming forward with a risk factor, or if they've had a fragility fracture at any age. That's a good time to start thinking about it, or if they get diagnosed with an inflammatory condition, or if they're needing medication that might impact their bone density, like being on steroids, for example. So that is a flag for me to start thinking about, could this person be osteopenic or osteoporotic? I think the next good time, from my point of view, is around that sort of midlife health checkup, if I'm lucky enough to have someone think to come in to do that, or when women who are increasingly coming in to see us around that sort of menopause time. That's another time to be thinking about their bone health. And then again, as they become more elderly, and of course, the sort of government rebated screening starts at 70. I think if we start thinking about osteoporosis in our patients at 70, I think we've really missed the boat. It's like waiting to talk about someone's metabolic health for when they become diagnosed with diabetes, or wanting to speak to them about their heart health after they've had a heart attack. It's not a bad thing to do, but we're also probably missing the boat there a little bit too.
So what are the high-risk patients that you think about?
So high risk would be increasing age. Sarcopenia, great to have a physiotherapist talking about muscle building and physical activity. Early menopause is really important, or amenorrhea, as was mentioned, really important. And inflammatory conditions as well being really important. So rheumatoid arthritis, for example, and other inflammatory conditions, inflammatory bowel disease, seem to have an increased risk of osteoporosis. And that's irrespective of treatment with steroids and those sorts of things. There seems to be something else going on with inflammation and bones. I don't know if did I mention family history? I think I did. Oh, okay. Family history, really important as well. And early menopause, I think the worst cases of severe osteoporosis I've seen are in women who've been through an early menopause, particularly those who weren't given access to hormone replacement therapy at a young age.
So is there any recommendations for screenings for women at different ages?
I think there's a couple of different groups of recommendations at the moment. So currently the RECGP guidelines are around considering fracture risk and risk of osteoporosis at around age 50. Certainly if someone's had a fragility fracture or a low trauma fracture, to consider their fracture risk at that point, and also at 50 for those who have any risk factors. And if you think about risk factors broadly, including smoking, alcohol, perhaps an inadequate diet, timing of menopause, history of amenorrhea, that's going to be actually a lot of the 50-year-olds that we see. And so actually I think perhaps generally if we're thinking about osteoporosis at that point, that's probably a good time to start doing that. And then again, screening sort of officially kicks in at 70. There was the release in 2023 of a practitioner's toolkit for management of menopause that was released by the Australian Menopause Society, that again suggested consideration of screening for bone density between the ages of 50 and 65, and to consider treatment in women at that point if they're considered to be at a high fracture risk.
Now, there's a few online tools out there. Do you use any of them, or do you find them useful?
So there's a few that come to mind. So there's the FRAX calculator, and if we do order a DEXA scan, many of those reports will come back with a FRAX calculation already as part of the report. The RACGP's guidelines do suggest for those that we are assessing their fracture risk at around that age 50 is actually to do a FRAX calculation and to send the higher risk patients on for a bone density if their risk is more than 10%. So that is recommended. Are we doing that enough in our offices with all the other things that we've got going on? Possibly not. But I think that is a useful tool. There's also the Garvin tool as well, which encompasses some more broad risk factors. The FRAX has got quite a small number of elements that it takes into consideration. And Osteoporosis Australia also has a patient interface for fracture risk estimation called Know Your Bones, which looks at alcohol and smoking, physical activity, history of early menopause, those sorts of things. And the patient can put those details in with or without a bone density score and then print out those set of results to take to their doctor, which I actually also think is a great way to start a conversation about bone health.
Now, if you've got a patient in front of you that might be at risk, what are the lifestyle or dietary changes that you recommend?
So, as you know, Travis, one of my passions in my work is thinking about caring for my patients from a lens of lifestyle medicine. So that lens to me is thinking of someone's lifestyle as the foundation on which the rest of their health is built, and then the other medical interventions that we might consider go on top of those foundations. So there are six pillars of lifestyle medicine, but again, I think of it more as a foundation. So they are food, movement, sleep, stress, social connection, avoidance of harmful substances, and I have recently invented a seventh pillar, which is sun, which is exposure to sun. And I think of that as being the basis of looking after someone's health. And a bit like if you're a builder, your foundation has to be in place before you put anything on top of it. Because if you don't have a good foundation, then you're not going to have a good building. So in terms of, the lovely thing I like about lifestyle medicine is that any intervention you make in there is likely to have more than one benefit. So if I'm looking at someone and helping them towards a whole foods improved diet, that's going to reduce their risk of osteoporosis and their risk of heart disease and their risk of 50 other things as well. So same with exercise. I mean, if I talk to someone about weight-bearing exercise, that's going to help their joints, that's going to help their bones, that's going to help their metabolic risk, their cardiovascular risk. You know, multiple birds with one stone is what it's all about for me. So, but specifically if we're thinking about osteoporosis, I think if we're thinking about food, avoidance of the SAD, which is the standard Australian or standard American diet, processed foods, low fibre, poor quality protein, those sorts of things. So a healthy diet without the sort of processed poor quality carbohydrates, without too much sugar, without too much processed food, that's really important. In terms of movement, absolutely strength training is absolutely crucial. Weight-bearing exercise, absolutely crucial. Avoidance of harmful substances. We know that smoking and alcohol, caffeine, carbonated drinks are all things that are going to affect bone density. And with my invented seventh pillar, access to sunlight, absolutely critical. Obviously, that needs to be done safely and in a nuanced way when we're talking about we're talking to our patients, because we don't want to increase their risk of skin cancer, but we need to get that right as well.
Do you do vitamin D supplementation?
Yes. But I think in a perfect world, I think I would need to give it less. So it's really interesting when you look at the data around vitamin D supplementation, that in general, even though it makes the vitamin D numbers that come back from the pathologist look better, it doesn't seem to help very much in the outcomes. So whether that's risk of fracture or cardiovascular disease or a number of other things, it doesn't seem to help. I think the main one it helps with is possibly the sort of MS kind of risk. That seems to make a difference. The rest, it makes you feel better because their numbers are better. The other exception to that would be if they are on anti-resorptive medication. That's really important that they're replete. But the rest of it, I think that we need to be focusing on helping our patients, get more vitamin D from the sun in an appropriate way. The second part, which I credit you with my increasing my knowledge in this area, listening to one of your podcast episodes, is that inflammation increases an enzyme that depletes vitamin D in the system. So for those who have a chronic inflammatory state, whether that's from an inflammatory disease or, in my opinion, and we will wait to hear from our endocrinologist expert on this, but even metabolic syndrome, which we see so much, all of those people have, well, not all of those, they often have low vitamin D, so that in their bloods they have other markers of inflammation with the metabolic syndrome and their vitamin D is low, which I always struggled with understanding until I heard you discuss that. But their vitamin D is low probably because the inflammation from their metabolic syndrome is reducing their vitamin D. So those people need to be less inflamed. That will help. And they need more sunshine as well.
So do you use any blood tests or imagings or anything to help you manage these patients?
Yes, and I think, I guess the tests that we do are going to be different depending on whether they have a diagnosis of osteoporosis or not. So in terms of tests, I think it's worth considering a bone density scan in those that, well, certainly in those that are at risk or have had a fracture. But I don't really, and I'm happy to discuss this further, I'm not really sure that there's that much harm necessarily to doing a bone density on someone if they are interested in looking at their bone health in the sort of middle age. So DEXA bone density scan at that point. And in an otherwise healthy person, the screening bloods I think are appropriate. If they've been diagnosed with osteoporosis, then yes, I would be doing regular, say 2 yearly bone density, and I would be measuring their vitamin D and their general chemistry as well. And then there are others who have osteoporosis that we're a bit suspicious might be caused by something else, and those people need to have those screening tests done as well.
So when do you consider treatment?
For osteoporosis?
Yeah.
Again, it depends on what lens you're looking at. So if we're talking about treatment in general, if I have a sarcopenic 40-year-old with no other risk factors, that's a great opportunity to be talking to them about lifestyle. So smoking, alcohol, exercise, diet. If you consider that to be treatment, then I don't think there's any time that you wouldn't consider having that conversation with your patients. In terms of other types of treatment, as I said, the Australian Menopause Society have updated their guidelines in the last couple of years to include consideration of hormone replacement therapy in those aged between 50 and 65 who have low bone density, not at the level of osteoporosis, who have low bone density and who can safely go into HRT. Previously, it was only for women who, primarily it was for symptomatic reasons, but they've updated their guidelines for us to consider that in low bone density in women of that age. And then treatment for osteoporosis, I would discuss that if someone has had a low trauma fracture or if they are osteoporotic on their DEXA scan. And that treatment would include medication and lifestyle, particularly looking at diet and particularly looking at strength training.
So when you're looking at medication, do you have a preference for bisphosphonates or the injectable treatments?
No, I think that always needs to be very thought out individually for each individual patient and their individual circumstances. So my general approach is that firstly, to talk to the patient about their risks and to encourage them to go onto some sort of medication treatment if that's appropriate. And I know that there are other GPs listening who will come up against, in many of their patients, a fear of the medications for osteoporosis. So talking to them about it first is really important. In terms of choices of medication, I do like the denosumab for the older patients. It's very well tolerated, it's easy, they come in twice a year for their injection. The younger patients, I am a little bit more hesitant about that choice because we know with the denosumab it's harder to stop, and there is an increased risk with the long-term treatment of things like the atypical femoral fractures and those sorts of things, and it's tricky if you can't give them a holiday. And again, I'd be interested in Dr. Nick's opinion on that as well. So we do certainly use all of them. I often find that the oral bisphosphonates aren't often very well tolerated because of things like the esophageal discomfort and those sorts of things, and they're sort of tricky to take and hard to remember and those sorts of things. And then we have others who are moving on to the IV zoledronic acid as well, because it's annual and it also gives you the opportunity to give people a treatment break as well, for whatever reason.
And just finally, do you have any other thoughts to leave us with or advice?
As you know, Travis, I love an opportunity to talk about how important good general practice can be. And I would say, as GPs, we have a very unique position and opportunity to ensure our patients have good bone health. And we know the outcomes of a major osteoporotic fracture, and the way that I explain it to my patients, particularly who are older, is yes, there are problems with some of the treatments, but if you're having a major fracture, you've got within 12 months, a third risk of being dead, a third risk of being in a nursing home, and the other third are often losing independence and quality of life. So the outcomes are bad, and so can it be prevented? And as you said, the development of osteoporosis, like many of the other things that we manage, doesn't happen overnight. It happens over years, it happens over decades, almost a lifetime. And I actually think in general practice, if we're really thinking about bone health early in our younger patients, I think that we've got a really good opportunity to prevent a lot of osteoporosis. Like I've had for the last few years in my practice a bit of a rule that I do talk to patients about, that none of my patients are allowed to have heart attacks. Not that I'll ditch them as patients if they have one, but I actually think that there's enough opportunity in our patient-doctor relationship to think about their cardiovascular risk and prevent that risk. And I'm almost wondering whether or not my rule needs to expand to, can I have a rule that none of my patients develop osteoporosis? My 65, 70-year-olds, we've probably missed the boat with, but the 50-year-olds and the 40-year-olds, how many of those are likely to go on to have osteoporosis, and how many of those can we turn around if we think about it early enough? And as GPs, we have the opportunity to do that much more effectively than our non-GP specialist colleagues, just because we are seeing people more frequently during their lifetime. So that's my call to action for GPs and bone health.
Excellent. Thank you very much.
Our next guest is Dr. Nick Kasmeredis, an endocrinologist with an interest in thyroid and diabetes management. He works in private practice in Adelaide.
Nick, with endocrinology, what are the key endocrine factors that contribute to osteoporosis?
First of all, I have to say that I completely agree with Alecia. I think that there are two aspects. One is prevention is still very important, and then you have the established osteoporosis, which probably, statistically speaking, is affecting more the elderly population. obviously, there's a lot of endocrine factors. I mean, and I think lifestyle is still the most important thing. And when we talk about endocrinology, I think endocrinology is a very confusing word. Yes, I don't understand it myself. The study of hormones, and we do not understand hormones very well, despite what we think we like. I think metabolic medicine is probably a better word, and this is very much the bones is part of the metabolic system, and that's where lifestyle comes into it. So I think one of the things, just probably to add on what Alecia has said, and particularly from the preventative point of view, is that we all build bone density from a young age. So at the age of 25 to 30, we've now peaked our bone density. And from then, it's a bit of a downhill. Now, unfortunately, it is what it is. It's aging, and obviously, it's a new concept, but probably also an old concept, where we now talk about healthy aging. So there's a lot of movement around the world about we need to age in a much more healthy way. So preventive medicine is very important. Obviously, bone density reduction and osteoporosis is, in majority of the cases, very preventable. And obviously, having a general good health is important in that. Probably the extra thing to add is, in the area of osteoporosis, a significant reduction in bone density happens in middle age in females. And this is due to menopause. So we peak bone density in a female around 25 to 30. Obviously, it seems to be pretty steady. And then around perimenopause, and definitely after menopause, women tend to lose a significant amount of bone density. So within 5 years of menopause, a woman will lose 15% of the bone density. Now, therefore, to avoid many people becoming osteoporotic in the mid-60s and 70s and older age, therefore, you can argue and say there is an opportunity of treatment at that menopausal age. Because if I can have some kind of a therapy to block reduction of that 15% of bone density around, say, 50 to 55, that's going to have a massive protective effects, particularly in that female. Now, the question then is, what do we do? Do every woman go on hormone replacement therapy? And again, that's obviously can be a controversial issue. There's a lot of things to discuss. But, the things which are not controversial is lifestyle. And I'm a strong believer, and I think I have seen, evidence in this area is not very easy to do. Those studies are not just easy to do, but I think exercise is extremely important. So obviously we have to really encourage that particular group of patients to actually, really become truly conscious, truly aware that they cannot live a day of their life without thinking about the importance of doing kind of, aggressive exercise, as I like to call it. So people just can't, forget about that area.
So if we're looking at hormone replacement therapy, does that actually negate the effect of menopause on bone health?
It does. So obviously the belief is that the osteoclasts, which are causing the resorption, are getting activated due to the reduction of estrogen. And this is happening even in perimenopause, where estrogen levels are falling. So obviously, by kind of supplementing with HRT, hormone replacement therapy, estrogen will have, in particularly, some effect on reducing that high resorption. I can't say it will, remove the whole reduction of that 15%, but it does have a significant effect.
Are there any conditions that affect bone health that us as doctors aren't good at recognising? Is there anything that we're sort of missing, that's saying this is an at-risk population or anything?
Yeah. I mean, I think, obviously bone densities are the easiest tool to diagnose osteoporosis, but from a lifestyle point of view, something that has become extremely common in our society is obesity, and in particularly the development of visceral fat. So I think that, people don't need to be 10, 20, 30 kilograms overweight to be unhealthy. Many people, when you look at them and you can do a body composition, you can see that they retain visceral fat, which is the metabolically active fat, while they don't have a lot of subcutaneous fat, which is the good fat. So people, the total weight may not be high, but when you do look at the body composition, you can see that they carry that inappropriate metabolic fat. And obviously that is a significant risk factor to metabolic disease. And unfortunately, metabolic disease like insulin resistance and type 2 diabetes and pre-diabetes and this cardiovascular inflammation that's happening in our blood vessels, there's a lot of relationships with osteoporosis because there is a significant crosstalk of the cells in our body. Inflammation is happening thanks to that visceral adiposity, and therefore I think, because I think obesity has become so common in our society, we have now kind of treated like psychiatry. We ignore it. And I have to say that this is something we probably have to now, again, we as doctors have to wake up and say, hey, this is not normal just because it's affecting 50% of society. We need to be aggressive. We need to call this as being abnormal. And obviously we have to, as clinicians, educate.
So when you're looking at potentially treating a patient with osteoporosis, do you have a preferred, either the drug mechanism of action, or do you like the bisphosphonates? Do you prefer the injectables? Is there any preference that you have?
So I do use a lot of all the drugs, unfortunately. I think as Alecia said, you have to individualize treatment. And obviously the anti-resorptive agents like the oral bisphosphonates, intravenous bisphosphonates, and denosumab, Prolia are very appropriate first-line treatments for osteoporosis or as a pharmacological therapy. I think that we have used those medications for many years, and they are very much rare side effects. They're rare side effects, and I don't want to overemphasize them because I think medications do give side effects, and we know that as doctors, and it's all about benefit versus risk. So we are happy to take that very small risk that can happen in few unfortunate cases. I think we're now prioritizing. So in many cases, you can argue that maybe in a younger person, maybe you should consider the oral bisphosphonates. And then eventually you have to consider stopping the oral bisphosphonates because there is probably increasing evidence that once you use the oral bisphosphonates for a significant time, close to 10 years, let's say, approximately, and that number can vary, the benefit becomes very minimal. So if you're going to be treating somebody with therapy, say at the age of early 60s, you can probably say, well, maybe I should consider the oral bisphosphonates, and then after 10 years, I have to assess, do we consider a very short drug holiday, depending on the improvements in bone density, and in some cases, there's probably not a lot of point for a short holiday, and you need to change them to a different therapy, and at this stage, denosumab will be appropriate.
Now, do you need to monitor patients on the injectables at all?
Yes. I think that, because bone density is easy, it's an easy test, I think it does give us an insight. Obviously, you can also argue how frequently, and sometimes doing too many bone densities may not give you too much extra information, but you do need to monitor, and therefore, as these tests are very easy, I think it just gives us a very quick idea to see if the therapy we're giving to our patients is working. At the same time, it's an opportunity to review those people and to actually emphasize, not so much the therapy, which is pretty easy, like, if you're having an injection, it's every 6 months, but to emphasize people and say, hey, are you still doing enough from a lifestyle point of view? And we can never forget that despite from a medical point of view, we do love to do a lot of pharmacological therapy, the biggest tablet is still diet and exercise.
Do you have any issues with compliance?
So compliance is an issue in certain individuals. So there are certain individuals that, despite our best efforts, they will not be compliant. There is studies showing that as people have been taking medications for a prolonged time, sometimes they start giving up. So there is that well-known phenomenon that has been seen in those studies. And sure, I think that there is something that does happen in the area of osteoporosis. And again, the reason for, regular reviews, so every opportunity we have to see that patient, whether it is to do some blood tests, whether it's to review bone density, is to emphasize compliance.
What is the rebound effect and how do we manage it?
So obviously the rebound effect is thought to be by a strong medication that inhibits osteoclasts. You inhibit obviously that reabsorption. Therefore, once the medication wears off, you do get a rebound in this kind of activation of those osteoclasts. So these cells are now that potentially have been sleeping are coming back and saying, hey, I'm back in action, I'm hungry. So the rebound effect is a well-known phenomenon and obviously can be dangerous in some cases. Again, probably not a massive rates of, concerns, but it can happen. So we need to be aware that particularly in people having the 6-monthly subcutaneous denosumab, that, we have to make sure that people are having those injections every 6 months to avoid the rebound effect.
And just any final thoughts or recommendations you have for patients or doctors that are listening? About osteoporosis management, or when would actually someone need to see potentially an endocrinologist about osteoporosis?
Yes. There's not many clinical endocrinologists, so the GPs have become the mini endocrinologist in this area. Obviously, there are some challenging cases in osteoporosis, and they're challenging because guidelines and treatment therapies, we just do not have enough evidence. And even when I sit in front of those challenging cases, sometimes I do not know what to do. So you have to talk to the patient, you have to explain to them what are the possible treatment options we have. And there are some challenging cases, particularly in investigating difficult cases. I think that osteoporosis is a common chronic condition. I don't think we need to have fear. And I did, I've heard this in a talk about exercise, very well said. And one of the things I tend to emphasize is that we don't want people to be afraid. We don't want to scare them about fractures. Sure, that's why we're treating osteoporosis, because we care and we don't want people to have these significant fractures that will cause a significant cost to the patient, to society. Life expectancy tends to drop after a significant hip fracture. So there is a lot of fear and definitely significant costs to our system. But at the same time, we have to be kind of consider osteoporosis as a common chronic condition, because we need to treat it the same way we want to treat high blood pressure. We want people to be engaged. We don't want them to be afraid. If I was to scare somebody and say, you have fragile bones, maybe that patient will go home and sit in a chair and do nothing and saying, okay, thank you, doctor. I will stay in my chair to protect myself from breaking a bone. So I think we have to make sure that we explain osteoporosis to our patients in a chronic condition, and people need to take charge of this. So yes, if you do have low bone density, you really have to protect your bones and you have to build bones. And again, as part of the non-pharmacological therapy, I think, people need to know that you need to keep your muscle mass to protect your bones.
Okay, thank you.
Our next guest is Dr. Steve Soukoulis, an oral surgeon specialising in dental trauma, medical compromised patients and periodontics.
I was just going to ask you, Steve, do you see many patients with osteoporosis?
In terms of the patients that I see on a regular basis in my consult clinics, we see patients on osteoporotic medications or anti-resorptives on a regular basis. It's something that we do have to deal with in terms of understanding patient care and then trying to balance out the risk profile that you guys have been talking about today with trying to plan their treatment. Sometimes it can get quite complicated.
So we've mentioned a lot of people are worried about this diagnosis, osteonecrosis of the jaw. Now, how common is this?
So thankfully, initially when these medications came out on the market and then patients were presenting with ONJ, there was quite a lot of fear. And so until then, probably past a good 10 years or so, then we understood that the rate wasn't as high. So thankfully that's come about, that understanding's come about. But certainly it's a consideration when you're doing surgical treatment. So at the moment, if you are on some of the anti-resorptives, and you are having a dental extraction, the rate varies depending on the study. You look at between 1 in 1,000 to 1 in 10,000. If you're on the injectables, then that's slightly higher, sort of sitting between the 1 in 300 to 1 in 500. And if you're taking, you're having, for example, the injectables with cancer treatment, it's significantly higher. In my practice, I don't see patients with that background. It's mainly for osteoporosis.
So is this something that's ever present when you're seeing in front of someone who's osteoporotic at all? Is it, or is it, one in
Look,
one in 100?
we do sit in the clinic for sure. So we've had, and it's interesting. We do. Obviously, there's a background expression of ONJ. So there are patients that present to us with spontaneous ONJ. I just had a patient only about 3 weeks ago present to me with a lesion in the palate, and literally it was because she traumatized the palate with a toothbrush. And so she developed like a 10-cent size coin lesion in her palate. Thankfully, this resolved with local measures, but it can happen with sort of minimal amounts of trauma. Again, because ONJ is a multifactorial disease, she had a number or a raft of other medical conditions which contribute to it. So it's not a one-to-one relationship with bisphosphonates or anti-resorptives and developing ONJ. So I need to make that clear to everyone. They're not. You definitely have a raft of different factors, and I think one of your other presenters mentioned about lifestyle and also the health in terms of chronic inflammation. We also see lots of patients with periodontal disease, which is one of a type of chronic inflammatory diseases. And so having this history of smoking, diabetes, periodontal disease, and then going on to these anti-resorptives can sort of contribute to its development. So it's hard to tell. The literature is focused on ONJ and dental extractions, but I do a raft of different types of procedures that are invasive, and we have very little data to give us an indication of whether or not the patients are at higher risk of developing ONJ with these other procedures. So it can become complicated, and that's why communication with the GP is super important, or the endocrinologist, of course, is very important.
Do you use the beta cross-laps or any test to help you guide you in your management?
Well, I do because it is a guide, but it's, again, because there's no one-to-one relationship, it just gives me an indication of what is happening with the patient's bone turnover. One thing I want to stress is when we look at ONJ, it's a combination of or delayed bone healing, but also soft tissue healing. So if we can provide patients with certain surgical procedures that minimize that trauma and then promote soft tissue healing, then we can certainly decrease the risk of them developing ONJ. But if I have a patient that's got a CTX test of under 100, that sort of starts to ring alarm bells. If we're sitting somewhere in a therapeutic range, then it's a consideration that I have to take along with some of the comorbidities that patient might have.
If a general practitioner is seeing a patient that needs to have a dental procedure done, what would you want the general practitioner to know before they send them to surgery?
Look, it's paramount that every patient that undergoes these types of therapies has a dental screen, and not only that discussion of, look, this is one of the things I find is that when patients come to me, they say, oh, look, my doctor told me that there's some mouth problem. And I look at them and smile and say, is that what they've said? That's about all they've said. And they said, yeah, there's some mouth problem. So I think there needs to be some more detail in what the conditions can be. I understand there needs to be a balance, as I agree sorry, I forgot the endocrinologist's name.
Nick.
Nick, yeah. So what Nick was saying was true, that we definitely don't want to lose the benefits of these medications because they can have significant effects on their life expectancy and life changes that are significant. But then we also have to understand that ONJ can be quite a significant condition that can lead to the resection of people's jaws. So the morbidity can be immense. And so we need to balance those two things to say, look, there's an oral condition that you can develop, which is called osteoporosis of the jaws. The best thing we can do before we start you on this treatment is to go and have a dental screening. Of course, sometimes the urgency of that screening, depending on what the patient history is, for example, patients with cancer, is urgent, and then they need to have a more aggressive look at their mouth and their dental status. As I think my introduction was, I used to work in the special needs unit. So when we saw these patients that were starting off with their oncological treatments, whatever treatments they were having done, we saw them and treated them in a relatively aggressive way. Any tooth that had a poor to average prognosis, we would remove, given the effects that potentially could have on their overall health. But when it comes to patients on antivirals for osteoporosis, we have somewhat of a treatment window, and then we can sort out patients' oral condition, get that stable, and then move on to the treatment, the anti-resorptive treatment.
When a GP sends them for a dental review, that's just a normal dentist, or do they need something?
Exactly.
They need something specifically said, saying consideration for treatment, or just a normal review's fine?
Look, a normal review, given the history that, look, this patient's going to go on to some anti-resorptive therapies, is the starting point. From there, it's really important, though, that, like, for example, I'm a periodontist and I have the colleagues that are oral surgeons. All of us look at things very differently in terms of, I can see this, and this. So it needs to be a thorough examination, including radiographs, and hopefully between two time points, like one previous radiograph and a new one, to look at differences. So that needs to be done in a dedicated way, and then report back to the GP saying, look, we've done a screen, we find no problems, please proceed, or look, there's an issue, what's the timing required, what's your thought process on the timing, do we have time to do A, B and C?
So we focus on osteonecrosis of the jaw. Is there any other complications that are important to be aware of?
Look, it really just depends on the timing of treatment for patients, and also the ability to undergo procedures that can have significant oral changes. So, for instance, functional aesthetic issues. So if patients go on to some of these medications, sometimes because of the risk that's there for ONJ, some patients say, look, I'd probably prefer to forego this treatment and have something else done. That treatment may not be the best treatment for them. And so it really relates more to, not necessarily, ONJ is definitely the primary concern, but the secondary concern is, are they receiving the best treatment and the best time treatment overall?
Now, is there any time that you would actually proceed with surgery regardless of a low beta cross-lapse result?
Yeah, particularly when they develop significant infections that may affect their airway or their facial swellings. You definitely have to go in and sort that out. Sometimes we try to defer any more aggressive surgical intervention by administering antibiotics and giving us a little bit more of a window. But then sometimes your hand is forced. You have to go in and carry out the treatment. And then again, we've developed some newer techniques in terms of extraction to minimise trauma. We also use obviously post-operative antibiotics and sometimes pre-operative antibiotics. And we also use things like platelet-rich fibrin, where we inject some of these platelet-rich concentrates around the surgical site to promote soft tissue healing.
Now, is there any final thoughts or advice you have for general practitioners, health people in this area?
Or definitely what I mentioned before was having one is definitely having a dental screen, but two, having just better communication between yourself and the dental practitioner. What I tend to find is I'm doing things in reverse, that I'm contacting the clinician after they've received the treatment and the patient has significant dental issues. So one would be informing the patients of what the risk factors are, including ONJ and what it is, and then two, if the patient instantly says, look, I've had significant dental problems, then that would be on a notepad writing a referral to the patient's dentist and saying, look, I really need a thorough screen of this patient, and then going back from there.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @DrTravisBrown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/IN/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.